Leaders, 75% of them, are not ready for this era of AI. We are living in an era that your knowledge is already obsolete in so many ways. So what I mean is this idea that learning is, oh, I'm gonna delegate to my teams to do the learning thing. I don't need to do that. Well, then that's a problem.
Today's guest is Dr. Rosa M. Colon-Kolacko, president and founder of Global Equity Learning. She's also the visiting researcher at Bentley University's business department and the founder of NeedHumans. Rosa's also adjunct professor at Tufts University School of Medicine. She shares how organizations can use AI, leadership, and human-centered strategies to improve healthcare outcomes and build more inclusive systems.
One of the things that I observe a lot in the health systems, we talk about the patient. And I always ask the question, but what about the people, the employees? So we created this movement of human experience. And for the first time, we said, let's talk about your experience as a person and the patient together. We need to stop to see people and not only see cause or see people like asset.
How do we bring about teamwork? How do we bring about lost culture? What did you do? Some ideas, and how did you sort of create the environment for people to feel, I belong here, I want to do more than just my paycheck?
There's a couple of ways. One way, for example,
Well, welcome to our podcast, When Health Freezes Over. I want to introduce you to my next guest, Dr. Rosa Colon-Kolacko. Welcome to the podcast, Dr. Rosa. It's wonderful to have you. You and I met in Vegas at a conference, and so it's been great to get to know you a little bit. You and I have talked a lot about your background, and you have worked in multiple continents. You're an adjunct professor at Tufts, and so you've done a lot in one lifetime. So please tell us a little bit, introduce yourself, and tell us about your work experience and where you are at today.
first of all, thank you, Omar, to invite me to this very important podcast because we need to unfreeze healthcare and make it move forward. So I'm very honored to be here. For me, healthcare, the work I have done is global. So I started my career, I'm very proud, Puerto Rican Latina woman that was born there, but I didn't stay there. My mom used to say we need to go places and learn and try to change the world. So I took that and run with that. So I left Puerto Rico around 1993. So in my venture to discover the world, but also change the world, my compass is elevating people, elevating all populations, and that took me to the UK after working in a big pharma company, a factory, like 1,500 people in Puerto Rico. I was given the opportunity to work in this massive two giants of pharmaceutical at that time to merge. So the Americans and the British, two different cultures, and I love culture, so I said, here we go. We did something similar in Puerto Rico, so we were the best factory in the network at that time. So the CEO and the chairman of the board came to see what do we do in Puerto Rico? How can we replicate that around the world? So so I was asked to lead the change management process for the whole merger and use Lean Six Sigma. And most important, how can we elevate voices of 53,000 people around the world to really see that this was not only about money, it's about patient, our products, our discovery products, and also about giving them a chance to grow. So for me, that was very inspiring. I did my MBA, I did my first research. So, how can we elevate knowledge management in organizations? How can we use the best potential and brain of our people, changing systems, implementing systems around the world? So, what I learned, took me to in many other places around the world. So, what I learned is we need to be ourselves because when you go around the world, you're different. I was not European. So I took that as a way to say, what can I do this in a way that create knowledge? So continue my knowledge function. So I was leading global teams around the world,
And mostly this was in pharmaceutical at the time.
pharmaceutical at the time, working a lot with CEOs, general managers, going to factories, and working with the chairman and the CEO of the new company Merge, which is Miklan Vision. That now there is a book on this journey. from promise to performance. Because during that time, people merged, make promises of millions, but they did not deliver. But at that time, we're talking about 1996, around 1995, 96, this merger did deliver. But there was a big difference. The big difference was the CEO, Jan Leslie, was committed to people. I traveled with him, the private jet, in so many countries that I used to ask him, why you don't send somebody else? And he said, no, 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 no. I want to be there myself for the people I'm leading. So this is also a concept of leadership. So I always remember him being on a big tent in France, and he spoke quite okay French, but we have an interpreter, and the interpreter translated what he said. And he stopped. He said, I wanted to say this differently in my French because he wanted to convey emotions. So it's all this connected to the humanity of how can we change through people with humanity, not necessarily with technology. So from there, I did my MBA, and then I went back to the US, and then I joined Bristol Myers Squibb, another big pharma. And then I started working more in technology. So we say, how can we technology will change processes? So my role have been HR officer, technology kind of officer, two people at Lean Six Sigma. So we spent a lot of time implementing SAP around the world. We was more technology driven. At that time, I decided I was going to do my PhD as an organizational psychologist, and I wanted to see how can we change behavior. So sometime, and nowadays is even more prevalent, we want to change and apply technology, including AI, in broken systems. Because in reality, processes are created by who? By people. So what it means is, what I learned a lot implementing SAP around the world is every country we went, and we used to implement a massive system in two countries at the same time. I always remember 4th of July was the weekend for Americans to be having fun. I was implementing systems in different places in the world. And what I realize is when you go and talk to people, people tell you, this is what my organization is doing, this is my org chart. Then we used to start doing more face to face conversations. And there were like people that were not in the org chart, there were processes that were very hidden. So we learned a lot that the change management element of the technology was critical. So as people may know, SAP is a German company. So change management was not a big thing for the technologist. However, we created it. We said we need to have a change management framework. My PhD dissertation was a lot connected to behavioral change, change management, and making sure that, which is so amazing how, is what we also need to do with AI.
What I mean, this goes back to one of the questions you and I talked about was along this journey of where you're talking about behavioral change and even your PhD in organizational behavior and psychology. What has been your learning, some of the biggest learning experiences throughout this journey? Especially what's interesting to me is when you hear things like quiet quitting, where people are just doing the basic amounts of work because they don't feel vested in the organization. You see a lot of burnout. You see a lot of people, not connect, especially with post COVID, a lot of people are sort of hybrid or were fully remote, not connected. And, there's a period where people had the upper hand. Now, employers seem to have some of back of the upper hand. It's become a very contentious, it's not a collaborative environment. It's a very contentious environment between the employers and employees. Even the team building is difficult to do remotely. You can't build that camaraderie. So what is, I guess outside of COVID, what was your learning experience for an organization, whether it's, health insurance companies or pharmaceutical companies, organizations in general, the ones that actually get it, what do they do differently than the ones that sort of pretend to get it?
I think that's going to take me when I shifted to healthcare delivery systems because I wanted to do whatever it take, and it's still today my mission in life, whatever it take to save life and make sure that everybody, regardless of how they look, what accent they have equal treatment with justice. So one of the things that I observe a lot in the health systems is something that is very relevant to your question. I came to Tufts Medicine as the senior VP, chief Equity and Inclusion Officer. So what we observe is that when I shifted from pharma to health system, we talk about the patient. And I always ask the question, but what about the people, the employees? So when I worked for de Blasio in New York City before going to Tufts Medicine of Chief People Officer, people used to ask me, what do you do with that title? Oh, Chief People Officer, what do you do? And I said, well, I take care for you as our partner in saving life so you can take care of our patients. Because what we discover is, in particular in New York, that they always say, well, you always care so much about the patient experience and the statistic, but what about, do you care about my experience? You know, something that we look into very closely. So we created this movement of human experience. And for the first time, I remember I'm going to create this movement. I'm going to invite people. And I open it to everybody. Then people start sending me emails about, why you haven't invited me to this human experience meeting? So we did a summit. And for the first time, we said, let's talk about your experience as a person and the patient together. Then we created this group, and we have for the first time nurses, HR, physicians, nurse practitioners, consumers, and stuff like that. Consumers came in as the second or third part of the process. And then we start looking at the data, meaning that if you look the data across, if you were dissatisfied in your unit, your numbers of customer satisfaction are low, medical errors are more higher, absenteeism, violence were not good. So it was an experiment, but with data. We're going to be an ecosystem.
It's interesting. I mean, it's a fascinating topic to me because health plans, specifically Medicaid plans, are bleeding out these last several years. They had a blip of money coming in through COVID because people stopped going using hospital systems. Like elective procedures dropped, so a lot of the MLRs for these Medicaid plans specifically dropped, and so they made money in 2020, 21, 22. They made money, but at a decreasing rate. 23 went lower. 24 was losses. 25 losses. 26 losses. So a lot of these plans are in dire straits, and so their immediate action is we need to cut costs somehow, right? I mean, when you're bleeding out, the first thing, strategy goes out the window, and you start to focus on, okay, I have to cut costs and retrench back to my sort of immediate fundamentals. But the biggest thing that they miss in cost cutting is what you just talked about: absenteeism, presenteeism, lack of teamwork. Everybody goes in their corners, doesn't share information. And so when you have, so and it was fascinating to me is this kind of cost issue is right under your nose. It's the people that you deal with on a daily basis. And I don't know of any health plan, and I've been in this business for 30 plus years, that spends any time. I mean, a lot of plans will talk about it, that people are our assets. But beyond that, I don't see any proactive work to ensure how do we bring about teamwork? How do we bring about lost culture? And it honestly, I have seen amazing leaders that create the culture just by themselves because that's who they are. And I've seen the opposite end of the spectrum where the entire team collapses because the leadership is so poor. Or there's such a churn leadership that there's not enough stickiness to actually have any impact. And so, what did you do? And I don't want to get tactical here, but at least some ideas on how did you sort of create the environment for people to feel like, A, I belong here. I want to do more than just my paycheck. Because, the whole concept of quiet quitting was I'm just going to do the least amount possible to justify my paycheck. And that becomes pretty pervasive. And so when you have that sort of attitude, you lose tens of millions. Imagine a place of 10,000 people, and imagine if everyone is quiet quitting all the way from the top to the bottom. Imagine the tens and tens of millions of dollars, hundreds of millions lost in productivity. Sick leave, extra sick leave, maximizing sick leaves. So I'm sure people are sick, but when you start to take it as a means to get out from doing work, or not wanting to put in the necessary effort, or not wanting to connect with your fellow employees, or hey, Omar needs some help, let me help him out, or like, oh, like, I'll just let Omar figure it out for himself. And so that's what happens when you have sort of a degrading of the company morale, because people are not vested in, because the organization is not vested in people, even though I think a lot of them try their best, but I think a lot of them are lost. At least that's what I've seen. I can't talk about health hospitals because I've never worked in a hospital, but I can definitely tell you my experience with health plans is it's sort of everyone seems to be sort of, wandering around trying to connect. And so I would love to know some 2, 3 points that you implemented in while you were at Tufts or wherever you were at, or what you learned even from your first CEO who said it was very vested in people. How did that sort of connection take place, and how did people sort of feel about it, based on whatever actions you guys took?
I think if we go back to London, and it's still so relevant today because this is like leadership 101. And as we know, in the era of new AI, the number one issue we have is leadership and empathy. Not only empathy is to be able to see that the digital is digital. Now is AI. In maybe 10 years, maybe something else. So what it means is he used to look at people and see people. Normally, when you talk to people that are very senior, they are looking at you, talking to you, but sometimes they're not even listening.
Right.
They're already worried about the meeting that they have with finance later. They see you because it's just a polite thing to do. So we need to stop that. We need to stop to see people and not only see cause or see people like if the people are asset. We judge people constantly in all kind of business setting. If somebody is late or something like that, it's like, so we don't know. Some people work 2 or 3 jobs, particularly in this economy, if they find jobs. Okay.
Right.
So what I mean is sometimes they care for people that are sick. They're caretakers at home. And sometimes we know people because of what they say in their badge. Oh, so you are the executive assistant. But do I know you? So it doesn't take a lot. People think, oh, well, that's not much work. It doesn't take a lot to know people and sometimes many people feel invisible. And if they feel invisible, why they need to give you the best to you in an organization? So I think that that's really number one. No, number two is use the data, not concentrated in cost solutions. Oh, everything is about cost cutting. Like sometimes I have talked to many HR people in my executive career that they look, oh, I have been saving so much money in the health plan, and oh, because I have a budget to save. There's no criticism for HR, but in reality, they give us target as an HR executive to save money.
Right.
And I get it, but if you save money, increasing the payment of the plan, what will happen with people in this organization that are not, I don't want to call people lower level because I'm so respectful from everybody at all levels. But if people have less money to deal with, they're gonna say, "Oh, I'm not gonna take the plan this year.
High turn. Right.
Oh, I'm not gonna go." I talked to Walgreens or CVS, Chief Learning and Diversity Officer, saying, they said, Rosa, many people of color that have low income go to the ED, they take the medication once. They don't come back for refill. We keep following up and they don't show up. So it's just like if we really it's going back to my point earlier. If I'm the people officer, I need to know the health of my people. And then we create a well-being program. Oh, let's implement a well-being program. Okay, but do you know the statistics working with the care plans and the insurance company to say where the inequities in my own people? How many of my own people haven't done even a colonoscopy according to their age? So I know there's a lot of HIPAA issues, but we just need to apply what we apply to the consumers to our people and then look at the data as we did it in New York. And also, tough when we start working on these things, we increase engagement scores. We increase trusting to the organization, even though the company at that time was having financial issues. But when after I left, my beautiful team, I remember sending me emails. Well, Rosa, everything that you did, you left behind, all those numbers went up because we really spent time giving voices to people, getting executive. We did a lot of work on microaggressions, or when we had dynamics on the team that cause people trauma and people get hurt, and that also caused people to not be as productive. So everybody were like with aha moments. But when you see executive learning with other people across the organization, you're showing vulnerability. You're showing, I don't know everything. And in this moment in time, the more we say, can you teach me? You may be a millennial, you may be a Gen Z,
Right.
you may be driving me crazy because this new generation,
Yeah, sure.
but I would like to learn from you.
Right.
And I don't think we are there yet.
Yeah. No, I think some of the biggest learnings I've had have been because I've been lucky enough to have a range of ages in our actuarial departments, all the way from 22 to 60 plus, and it was one of the greatest experiences I had and continue to have because of exposure to multiple generations. And I think if you're open to learning, you can learn from everybody, and I think that that's the fundamental key. And of course, as you said, what we do in investing in, and now here's the interesting part. So I'm going to be interviewing a gentleman who talks about how the insurance entities are probably the lowest on the trust scale by members.
Yes.
So here's an industry, unfortunately, that has very low trust by members and is also not doing enough for retention for its own employees. So it's sort of being hit, sort of thousand cuts both on the employee end and on the membership end. So it's a fascinating industry that seems to. I'm hoping it catches on in terms of what's everyone other industries are doing to retain talent and retain membership and retain patronage of its prospective clients. But what do you think? Let's talk about day-to-day work. Where are you engaged these days in terms of your day-to-day work, and what keeps you busy?
Oh my God, a lot of things keep me
I
busy.
know you're always on conference calls.
But I think a lot of things that keep me busy is to be a thought leader in critical elements that impact not only patients, workplaces, countries overall. And this is going back to what you said about learning. We are living in an era that your knowledge is already obsolete in so many ways.
Right.
So what I means is we need to keep reskilling ourselves almost every six, every 10 months because something new is out there. So we did a research with the Future Talent Council, which is a think tank of people globally. I'm very honored to be a strategic advisor for them. We do convening around the world. I just came back from Mexico 3 weeks ago. Before we were in Abu Dhabi, and we're gonna be in Boston on April 7th, and then we're gonna be in Malta on September. So we bring all these thought leaders together, and we have all these people talking about latest research. And but not only that, then I apply it with my clients,
Right.
meaning that when I go and talk to people, I bring what is the latest thinking, the latest tools, evidence-based tools. And then one of the things that they're saying is what you learn today will become obsolete in less than 2 years. So what I mean is this idea that learning is, oh, I'm gonna delegate to my teams to do the learning thing. I don't need to do that. Well, then leaders, 75% of them right now, are not ready for this era of AI. So then what we do is like, oh, we're gonna purchase ChatGPT licenses and cloud and Anthropic, and we go out there and do all of that. But in reality, do you know how to lead AI as a leader? That's a problem. Because when you're at the top, which I've been a C executive for a very long time, who is responsible if something goes wrong?
Right.
If there are ethical issues, if there harm for a patient, at the end of the day, the top is executive need to be responsible.
Right.
So one of the things that I'm spending a lot of my time is to go out there to say, critical thinking is critical, and we are losing critical thinking because and there is an author, Professor Gilrich, and he talked a lot about the concept of uploading of offloading. So what leaders do, what we all do right now, and some people that really are a fan of all these different tools, you need to write a presentation about something. You go to any of these tools and you say, "Oh, I need to talk about this topic. Tell me, this is the question. Tell me what you think." ChatGPT or whatever. And that's what we call offloading. You're not sharing or teaching them machine learning your point of view. You allow them to inform you of your point of view. And that is what is killing like 40% of critical thinking of our leaders or even employees are declining because then you're not thinking. So the idea is that we need to do what he calls, that's why I'm quoting him, uploading, is that you have your point of view already. You've written a paper, like you are an expert in insurance, so you can say, "This is my point of view, ChatGPT or cloud." But what other point of view have you seen around the world? And then the uploading then doesn't stop there, which is what we do with NeedHumans. It means that then you take that concept between your brain, the machine brain, then you take it to your team. I said, we are trying to change this process that is broken. This is what I believe, and this is what, together with the chat GPTs of the class of the world, Anthropic of the world, this is their opinion. Let's have a conversation. So the idea of reflection, the idea of co-creation with your team is what we need. But that's not what we're doing. So that's what we think we've been creating. I've been very busy creating playbooks, different tools to help leaders understand. And the daily people that do the work, everybody can use the brain of AI. But your brain is more important than the brain of AI. Because then if not, there's a lot of hallucinations, there can be misinformation, and then you're gonna stand up in front of an audience to present something that you didn't create yourself. And then people are going to ask you questions. You're not going to have a clue. So I spend a lot of time there. And also the other thing is, how can we design solutions that are human centric to consumers, to patients, to payers, meaning that there is a framework. So one of the things that we're trying to do is don't involve your consumer or your patient when you already designed the product. So when I did my certificate in Harvard, that's what I learned. The more we bring people early in the process, like for example, in the European Union, they're making mandatory that every company need to train people in AI. It's mandatory. So it's not nice to have. You cannot give them tool without that. So what I'm saying is the more we use the our patients, our communities, even consumer, no patients, they have lived experiences. Then the other issue that we have is that the majority of the people building solution in AI are not diverse.
Right.
So what I mean is these professors sometimes say, unconsciously we're creating racist systems. AI is may not be as multicultural, thinking about different needs of the culture because the people building it are not that culturally aware. So if 80% or 70% are not diverse or from different countries in the world, it's like medicine. Remember the question I asked about if we don't develop drug discovery with the right representation of populations, then those drugs are not be applicable for everybody. And people can have side effects. So the idea is how can we shift the mindset of bringing people early and don't use the excuse, oh, but what do you want me to involve my community? They don't know anything about AI. Well, but this is the time to teach it together. So we can then co-create it in a way that they will trust us because the other issue that in healthcare is not trust.
Right.
So now people are saying, you want me to teach to use this machine? I didn't trust you before.
Right. Right.
Now I'm gonna trust you less.
Right. Right. So, are you right now engaged in different types of industries, or is it one particular industry you're focused on? And when do I guess leaders reach out to you when it's palpable that, oh my God, our people are just it's not working within the organization, or do you have visionary leaders who say, you know what, I want to make sure that the amount of effort we're putting in our members or our clients, we're putting in our staff as well. When do you get engaged, and how do people bring you in?
There's a couple of ways. One way, for example, we're working with an organization that developed an AI strategy. At least they have one. Many organizations don't have a roadmap,
Right.
or if they do, it's very technical. Okay, so then what I keep saying as a broken record, AI is not about digital. It's about changing how you work, how you behave, how you relate with each other. Changing the roles of leaders is more important than adding more AI tools. But we're spending more money in AI tools. So they developed a strategy. Now they wanted to have a playbook into how can we make sure that they use a strategy to design solutions that are equitable and human centric. So we're developing a set of applying our tools into their framework and also allowing leaders to bring consumers or patients to the mix. And also, how can you going to measure impact? So it's not about designing a solution that you like. It's designing a solution that deliver what? Is it only cost effective? Cost effective is not the right only thing to concentrate, to focus. So it's defining those things. Sometimes they engage me through, I have different network collectives, so I bring people together. I bring in like convening, like for health equity, we have a convening that I shared with you before, which is how can we measure health equity across the ecosystem, bringing the payers, the health care delivery system together, and looking into how can we stop competing. Health systems compete with each other. But should we be competing in an era that there's so much inequities, funding cuts? So the idea is how can we create instead of having five different tools of measuring impact, having one tool where we can see in this zip code, this is how the payers are doing serving that zip code, inequities or equity issues, or where we have closed the gap in inequities, and then where are tools in AI that we have applied that have been successful. So I also bring people together. I do sometimes podcasts or LinkedIn just to share some of the latest things that are happening in the world. And then with human resources, we look again, how can we make the AI be human and also looking into policies and processes and avoiding applying AI to rocking systems. That's one thing that I'm trying to do.
Yeah, and so you and I have talked about SDOH or health-related social needs or whatever the terminology needs to be, and we've talked about it from a perspective of members for patients at hospitals or members. Have you looked at, I mean, are you trying to incorporate any of that for employees, whether it's healthcare, whether it's any other industry? Because, you would think that, employees are just as vulnerable as members. If their housing is a problem or if transportation is a challenge, or if their food deserts or food insecurities. And I think you and I went to that conference where we talked about language issues. I mean, those are issues that are pervasive and challenging for everybody, especially minorities, obviously. Is there anything that, you've seen that one can incorporate any of those things, or how do you incorporate, especially, especially given the lack of funding for SDOH? How does I'm just sort of curious as to my own knowledge here. How does one sort of look into that, not just for members, because that's a major issue, but also for your own employees?
Well, I think this is the conversation we started in Vegas. And for the audience, we were not playing in Vegas.
Yeah, no.
We were learning a lot about health equity and SDOH. I think the main issue we have with SDOH is that it's being treated as a nice to have. As and we have a lot of discussion, and right now we're gonna write a point of view about this for those interested listening, that SDOH is like quality and safety in a health care delivery. Is not quality and safety is the heart of care. And if we don't address SDOH, according to the research, SDOH influence like 80 or 60% of the outcomes.
I know it blew my mind. I thought it was 50, which was large enough, and then turns out it's like closer to 80%.
Yeah.
And it's like it wasn't stated by one person. It was multiple people that were at these conferences stating 80%. I don't know if they're looking at the same study or not, but I mean, 80% is massive. Just from an actuarial perspective, if you think about it, you're basically mispricing a product. You're off by 80% because you are not incorporating sort of a major contributing factor to claims cost. You're just looking at utilization and unit cost, and then you're looking at historical. This is for what actuaries do, right? Look at historical mix of members, et cetera, benefits, and then they try and project it forward. But the reality is, one of the things I've always stated is that and the irony to me is just when it comes to health plans is if we can incorporate SDOH, and I'm not even addressing the issue with members, with the employees. That's another whole issue. That's a G&A issue that which can be addressed, which is such an unfortunate part that it's systemic to the entire environment that we're in. And so, if you're able to address SDOH to some degree, let's say for a second I always said, okay, let's say you ignore the 80%. Say, okay, that's too much. I don't buy any of it. Let's say it's 5%. Okay, we're down to 5%. Think about the margins that currently exist in health plans. They're like 1%. I mean, United Healthcare lost half its stock price last year because they missed their MLR. So imagine, even for United, which is the giant in the world when it comes to healthcare, 5% will have a massive impact. Then think about all those regional plans out there that are bleeding out and, you know, concerned about basically going belly up. And so if you're able to incorporate 5% of those SDOH impact into your pricing, suddenly your MLRs improve dramatically. Suddenly your membership retention stays because they're not pissed at the health plan for XYZ reason. Maybe your churn reduces. Okay. Next thing you know, the state's budget improves because they've got less churn and predictable MLRs. And they're able to manage their budgets better because you're now having an impact on the long-term member's health because you've addressed the fundamental issue. And that's what I'm saying. I'm not even saying ignore the 80%, ignore 50%. Let's go down to 5. Is it not worth it at 5? And so I think about that from a member perspective, but I then think about that from what you're talking about is for an employee perspective. Think about what that would do for employee retention. Not everyone is lucky enough to have a comfortable home and have the money to pay bills and drive everywhere to work. There's a lot of people out there that are struggling. We all know that. We see that on a daily basis. And, when you're making decisions between housing, food, and medicine, you've got, it's a large swath of the population, the impact of SDOH and, culture and everything that you're talking about can have a material impact on, and this is not just health plans. You can talk about any industry.
Yeah, because what happened is
Hotels.
we confuse programming. My comment about I can save money in the health plan, impact people that don't have good salaries. Then the other issue that we have is we love well-being. Now well-being is the thing. Oh yeah, now we move into well-being and oh, I'm gonna have an AI person, an AI agent that can talk to you. You're depressed or which is important. Again, I don't want to undermine that we have proved that there are some AI agents that, with listening to people, are really help them socialize some of the depression they're going through, in addition to later on go and see a real provider for help. However, we need to connect well-being with SDOH because if we create a program without addressing the social determinants of health that are hurting our employees, to your point, then maybe that's where the payers should be working together.
Right.
Saying it's not only about reducing the payment of the insurance for my own employees, is why do you need to, how can we work on this SDOH together?
Yeah.
Not only for the employees, I think if we are looking at this together, HR can make a big difference to our people because really we don't even know because people sometimes are embarrassed that some people are. I used to have a lady who was homeless and I didn't realize it until I opened up and she was honest. So unless we start that way, then well-being will be super powerful. And then for the patients, I'm into the ecosystem. Unless we bring the ecosystem of healthcare together
Yeah.
and say SDOH is critical as quality and safety is, we change the rhetoric. And I think, I don't know, the payers understand that they can save so much money,
Tens of millions.
tens of millions of dollars that can translate to revenue.
Goes
Because
to the bottom line.
the only thing is this is about money and that's not really my problem. Well, if you want to have more margin,
Correct.
and then UHR, if you want to have more retention or
Correct.
less absenteeism, then
Correct.
this is your answer.
Correct. So this brings me to my final point. How do you think actuaries and folks like you with organizational psychology backgrounds can we work together? I mean, actuaries aren't psychologists, but they know the bottom line.
They want the money.
They know money.
They
right?
want no money.
So how do you integrate these two sciences to help and to really inform industries on how to, by checking the health of your employees and your members, you can actually directly translate to financials. How do you think we should all work together?
Well, not only for employee, for the patient.
Yeah.
I think because we need to go back to the example for New York City, the city of New York, meaning that we look at the data across. We look only at the data of how much this employee paying per month.
Right.
But do we look into the data by the BMIs, the preventive, how much the preventive work they're really doing, okay, versus how much money they're making. So you can start looking into Well, if that person make that little, they're not going to have time to go and do all these things because they're deductibles. The prevention is not for free. So then if they look into that and use because we normally have, we call it the frequent flyers, those people that always go to the AD,
Right.
or those people that wait to be very, very sick.
Right.
Then they're weeks in the hospital that
Right.
costs more money.
100%.
So I think we're not looking horizontally and vertically at the data,
Right.
because as you know, payers look at their data.
Yeah, I mean, I know for a fact that actuaries rarely look at SDOH data. I mean, I've been doing this for 30 years, and I've rarely looked at any SDOH data. I know it's residing somewhere with the providers. I know it's residing in the provider databases that our clinicians used to have in the health plan when I used to work there. But actuaries would just look at claims. And claims is basically sort of, to me, the manifestation of your poor choices or no choices of food and whatever else that happened to you. Right? By the time you get a claims, it's already too late because you're already a diabetic.
It's too late. You cannot change
You
it.
can't change it.
So,
You're already a
but
diabetic. You already got congestive heart failure and obesity and what have you. And so it's late. Now you're just paying for claims where the health insurance entity had sort of time to impact that member's life years ago, but it couldn't for all the reasons we've talked
well,
about.
for that reason, the lesson learned from the Vegas conference was that you have a bunch of SDOH practitioners with all this passion. They
Right.
want to make an impact.
Right.
Then you have health equity practitioners,
Right.
health equity officers and directors doing the work completely in a silo.
Yeah.
So when I did my workshop in Vegas about SDOH and health equity, people were looking at me, well, I know there is a health equity department over there. We talk often, but we're not working together. So unless we say, let's get the health equity people, the SDOH, and then bring the payers together, and then maybe get HR and the payers, I think we just need to change the conversation and at least give it a try. If we take this idea of the dashboard across, then we're gonna see a different picture because they're not gonna listen if we don't have the data to show that their money in here. You invest maybe something, but you get more money. But this is not rocket science, but it's not something we can do in a week.
No. Obviously, it requires
Shifting,
vision and it requires time and energy. Yeah.
but
All these things.
they can increase revenue if they do.
Yeah.
And and just to summarize as well, at the end of the day, it's about people's life expectancy.
Yeah.
We know life expectancy now is continuing to even decline
Yeah.
in some people that the funding cuts are big. So what I mean is just put the people in the middle, in the center of all of this. And then the money will come as a return,
Okay.
but it's got to be intentional.
Excellent. So, Dr. Rosa, can you give me your sort of website and how people can reach out to you? Maybe speak out your email and your website.
Yes, so you can find me in globalequitylearning.com, also in LinkedIn by Rosa Colon-Kolacko. The NeedHumans movement is in LinkedIn. And people that want to join us, that in reality is not about the machine, it's about the human that we can make a difference. You can connect with me, and my email is Rosa, simple, CK, my name is too long, Rosa CK at globalequitylearning.com.
Fantastic.
Thank you
Thank
so
you
much.
so much. I really
Great
enjoyed it.
conversation that will continue.
Yeah, for sure. We're gonna have more of these discussions going forward. I think it's a very critical discussion for just to the fundamental survival of how and I'm talking about health plans specifically, given all the sort of changes taking place and how tumultuous the environment is. I think this is one of those things that can be addressed longitudinally and have a very material impact on the survival of health plans going forward. So thank you very much for your time. I really appreciate it. Thank you. Thank you, everybody. We will continue our discussion in the next podcast that'll be released in the next few days. Thank you very much.
Thank you very much.